I'm very honored with this big honor to give this lecture. I remember when I meet this time because I'm Genevas, it's a lot of years ago in this world of the sleep surgery, and I remember when I see one of the lectures, I'm surprised with the level, and they're very humble. I remember when I go and present, introduce myself, hey, I'm Rudolfo, Lugo, Mexico. Very humble people, very like the Mexican people. It's, I don't know, Latin American people. It's like that. I feel like we are partners and brothers, and we can share this passion for this field. We come to Mexico, like my friend says, it's in another, it is exactly in another part of this planet. We love the tequila, the party, the food, the spicy food. You need more spicy. I don't feel nothing hot here, but okay. This is a volcano. It's our field's land of volcanoes. My city is in the northeast. It's not a colonial city. It's a modern city. It's industrial. A lot of factories there. 7 million people live there. Monterrey means el rey de la montaña, the king of the mountain. Is that the reason that name Monterrey? And we are from Monterrey. The people from Mexico call us regios, like from kings. Is that the nickname? It's a lot of buildings and surrounding from mountains. And this is an example of our foods. The tortilla is over there, and your what is the name of the flatbread? Chapati, yes. And that is a chicken with a lot of peppers and spicy sauce, black one, with chicken, with the rice, well, like your dishes I tasted, and the tacos. After you eat with the hands and eat, we eat with tacos. This is the reason we eat with the hands, and we are a lot of jokes. We do a lot of jokes with the Americans, with the United States people. Go to Mexico and eat with the fork, and oh my God, oh, it's spicy, man. Well, okay, we have that neighborhoods, and you know, DISE, look before you leave, is like always you need to see, and if you want to make a step, the elders always says, hey, you need to see where you walking, where you going, and you know, is this some pictures from my former fellows right now? They are sleep surgeons and sleep ENTs right now, and always the first encounter, the first step in our fellow is perform a DISE, and they. I know to use the endoscope, okay? Put it on. And, oh my God, I put the turbinate, bleeding, I have bleeding. You have bleeding in DISE? I don't want to see you in the part of surgery. You know, this is very different point of way of think. It's a different concept to involve in the sleep apnea and group work. And this is an example we have. I love to use this example because we see the versus awake versus asleep. It's the same patient. Look the difference between the sleep patient in the left side, in your left side, in the right side is awake. Look the pattern. It's totally different. We see the uvula work in the awake, and you don't have any work in the uvula in the sleep. You sleep, you see the tonsils there, the lateral pharyngeal wall there, but you see in the right side another kind of obstruction. Is that the reason the simulated snoring is not the same to the real snoring. I know, it's a DISE. It's a dual-induced sleep endoscopy, all right, but it's the most similar tool we have to see in action the patient during the sleep. I was born in 1969. I was born in Linares, Mexico. It's a little town very close to Monterrey, 120 kilometers from there. And this is my year of was born, and last year. Look all the papers right about DISE. In the pandemic, then year 2020, you see all the people in the houses, in the offices that start writing because you don't see patients and start writing. It's not the reason he has a peak there. We have peak there, but you look all the studies we have in DISE. And in that papers, I have one, my favorite paper in all that papers is one of our friend, Olivier van der Beeken, a monster from Belgium. This is a big guy in this world and truly a good guy. And he studied about 1,249 patients in DISE. And he looks the percentage obstruction. Oh yes, palate is the most common, without doubt. But you see the percentage in basal-tone hypopharynx and multi-level. And we see in this paper the level, degree, and direction. We don't have any doubt about that. The level is very important. The palate, oropharynx, tone base, and hypopharynx. The degree, we don't make big waves there. It's complete, partial, no. You have complete, you have partial, you don't have any obstruction there. And the direction, anterior, posterior, lateral, and the concentric, but the concentric is not real concentric because the posterior wall don't have movement. It's a lateral anterior in the same time. Lateral anterior, we see in some patients more lateral than anterior. We can make percentage there. It's more lateral, more anterior, middle lateral, but it's concentric. But all the people tell concentric is good to say that, to tell them. The palate, the oropharynx, the hypopharynx. The palate is very easy to see, the flutter, but always looking for a little movement in the upper part of the palopharyngeal muscle. In some patients with anterior flutter concept, we see a little movement in the muscle there, in the upper part. It's very important to see that. In the oropharynx, we can see the tonsils and the lateral wall. And you know, in some patients, you can see a grade 1 tonsil. When you see in a sleep obstruction, in the sleep endoscopy, you see that tonsil is going out and blockade the airway. And you, what grade? How is this patient? Grade 1. Wow. In the sleep endoscopy, we see a lot of difference. The basal tone, you look the basal tone there, collapse the epiglottis in some part, secondary obstruction of the epiglottis because we have a complete obstruction of the basal tone. But we have another kind of obstruction hypopharynx. When I see a collapse in the basal tone, 100%, but we can see an intrinsic obstruction of the epiglottis too. Is that the reason we need to look that kind of obstruction? And the anterior posterior, you can see that lateral there with a little collapse in the epiglottis too, and the concentric, like I say, is lateral anterior in the same time. You know, the lateral we can divide in complete and lateral partial. Not complete. It's very important because the only reason I perform a lateral pharyngoplasty 6 version from Dr. Cajali is a complete lateral collapse. When I see a lateral complete collapse, I perform the classic lateral pharyngoplasty from Dr. Cajali, the 6 version, the lateral. But is the only technique I perform when I cut the muscle. It's in the lateral frontal. In another kind of obstruction, we can perform another techniques. Just this obstruction, lateral complete, obstruction to the epiglottis area too. The lateral partial, sorry for that, the lateral partial is only in the upper part. When in the basal tone hypopharynx, we don't see any obstruction. If you want to see that concentric obstructions, you can use your cell phone, take a picture of this slide and go to the code, that code, and you can go to see in your phone the obstruction. This is one part of our book, and you can see the various obstruction patterns in that QR code. Okay. The vertical patterns, anterior, posterior, lateral, partial, concentric, basal tone, complete. Okay, we have the collection of all the obstructions. It's very, very, you know, the gallery of the obstruction. Okay, we need to make our eye very, you know, skilled to see the variations. This is the reason you need to see options and difference, because we can see some variations like this. Reflux. Always talk about reflux, but never see the reflux. Look the reflux. Biliary acid during the DISE. When I show this video to my gastroenterologist, okay, I believe in the acid and the pharynx problems, because the gastroenterologists don't believe in the pharynx reflux problem. Right? This is another kind of patient with a glottic collapse and vibrate flutter of the area. You look at all that particular aspect of the vocal glottic area, and you see how in positional he collapses and make little sound. This is so funny, because you see some cataphrenic patients and you hear something weird. No, it's like a, it's not like a, and you, what's that? And you can see some pattern like that. And this is a patient, a little boy with a laryngomalacia, bad management, make a tracheostomy there. The patient never use the vocal cords, take out the tracheostomy 6-7 years after that, and make the ankylosis of the vocal cords, and he has a severe apnea because the vocal cords. And this is very difficult to intubate, you can imagine. This is the reason the apnea is only produced by the vocal cords. And some doctor, no ENT, is a skeletal surgeon. Hey, we make an MA and cure this apnea. And I tell my friend, no, if you make a skeletal surgery, yes, you can do something like that. Aesthetic is nice, but the problem is still there. And you operate and the patient is still with apnea. You need to see the obstruction. I don't know. All right. This is an example. We show quick samples of our DISEs. This is a male endoscopy room with DEX. It's almost severe apnea. The supine and lateral position interventional with the lip dentist and CPAP. This is case from years ago, a lot of years ago, with our protocol. This is very important, that case, because it was my first patient when I used the CPAP during the DISE. And you need to see why we start to use always in our DISEs, in our sleep endoscopy, to put CPAP. As the lip dentist, put the simulator of the oral appliance previous to the study. You look the oral appliances, he talked with my patients, dental history, all that stuff we need to put the simulator. Is it the normal snoring? Oral breather, always. Look the neck, look the effort he need to make to breathing. And this is the first part of the study. Look the vibration, little obstruction of that tissue, soft tissue. Always when I go to the DISE, always our anesthesiologists know the oxygen nadir. This is very important because if this is going lower, it's over-sedated. It's very important to see that variation. Look the epiglottis in respiration, look the base of tongue, look the epiglottis. You need that area. We don't see anything in the epiglottis. You see the base of tongue and you see the palate, all right. We put it in right position, all right. We can see the variation in the positional aspects, okay. When I see positional aspects in the sleep study, we go to positional DISE. It's very, the DEX is a long duration drug. It's not depress the breathing rhythm. This is very important to us. Look the palate, look the epiglottis, okay. Go to the other side. Like the Sherwin system, we have a side. It's very hard to change the side. We have a side to sleep. The physiological and the favorite. It's very different. In some patients, the favorite is the physiological. Wow, nice. But in some patients, the physiological not the favorite, and this is a problem. This is very tricky to think in that. Look, the base of tongue, epiglottis. All right. Put the oral appliance in that time we use that oral appliances simulator. And sadly, we don't see any relief in the obstruction, in any relief in his collapse. I don't know if I have volume there. I think they have, but it is not have, don't worry. Look the base of tongue, look the epiglottis. All right. Okay, the patients tell us, I use the CPAP, doctor, and I feel shocking sensation, and I take it out 2-3 hours. And the therapist, sleep therapist, you need BPAP. Okay, put in BPAP. Okay, you need a servo ventilator requirement. Is that the reason we go to the ENT? Put the CPAP. We put the CPAP in this patient. And look the epiglottis. Never in the study see the epiglottis obstruction. Only when we put the CPAP. And we can see the problem with this patient. The problem was the epiglottis. Is that the reason with this patient we always, almost always, without go to DISE, we go with our CPAP. Because I need to see the upper airway during the positive pressure therapy. As another example, Down syndrome, persistent sleep apnea, like doctors show a lot of patients, pediatric patients with sleep apnea, posterior to tonsillectomy and adenotomy have the same complaint. And the doctors, some doctors don't want to perform DISE, and some ENTs don't believe in the DISE. I don't understand that, because it's not like a Buddha, like a, Jesus Christ, it's not a religion. You don't need to be a believer. This is a tool. And some sleep ENTs, I don't believe in DISE. Okay, but what to use? Oh my, only open the mouth. This is procedure. In this patient, still with the problem, has a little residual tonsil after the surgery, has the transverse problem in the maxilla. All that stuff you see in this kind of patients. Go to the DISE, look the oral breathing, the effort in the thorax, in the sternum, and the neck. Okay, the parent asks to everybody, what is DISE? Why the pediatric ENT don't want to perform DISE? And look the lingual tonsils. I see a doctor, he wants to make the operation right now. I see you, I see your eyes. When you see that lingual tonsils, Dr. Videsara, you know, this is the lingual tonsils there, and the little epiglottis problem there. This is in positional. We see the same problem with a little opening there. Is that the reason the mother tells us, my little boy always in the bed has this position in the end of the night? Yes, because he wants oxygen. And he put the head in some weird position. And is it the cubic, the lateral positional? And in the left side. Poor boy, it's a totally obstruction children, and we need to take out that lingual tonsil and make a little work in the epiglottis. Oh, doctor, you have problem with the epiglottis. You cut the epiglottis. What? I don't have any problem with that. This is like, this is, you know, we need to take the points very, very clear. The CPAP. The CPAP intolerance is very common. You see, we are two different CPAP intolerance. The CPAP, when the patient don't want to use it. This is the cognitive, psychological patients. They use the CPAP when they don't have good outcomes. No, sorry. He used the CPAP. He has a good outcomes with the CPAP, but he don't want to use it. I don't want to use it. And you can perform anything you want, call by phone, go to the psychologist, sign a letter that the patient not use the CPAP. This is the truth. And another kind of patient, okay, I want to use the CPAP, but I don't have good outcomes. Is that the reason we don't see the CPAP intolerance, the difference? And come for all that stuff, talking about the adherence, the high failure in these kind of patients, and the symptoms of CPAP therapy is one of the major reasons to contact the sleep studies, sleep labs. And you know, when I go to see the patient, when they use the CPAP and go to ENT, it's because we have these kind of symptoms. I still somnolence, I have nasal problems, I still snoring. And relationship, this is a paper we worked with my fellows group last year, and we talk about the relationship between level CPAP titration with the phenotypic anatomical variables and the drug-induced sleep endoscopy findings. And we can see in some patients, the hypopharyngeal area is the tricky area. Look, these examples, DISE with no CPAP, normal DISE with the tonsil there, the basal tonsil obstruction, the epiglottis is a normal position, but the lateral wall is still collapsed. But the problem, the patient is with collapse. We put this patient under CPAP. You look the variation during the pressure. Is that the reason we put this pressure in this patient stabilize the pharynx and the patients feel good? You see this is a good titration of the CPAP. But we can present these two examples. No CPAP, the patient is a typical patient. I want to use it, doctor, but I don't feel good. I take it out. Okay, the tonsils, a little fat, the flutter, a lot of snoring there. Okay, I think we have, you can put the, please. The basal tongue and the epiglottis there, no CPAP. Look, no CPAP. put the CPAP, his proper CPAP, is the patient CPAP with the own mask, and look the epiglottis. The first time of the study, the first pressure setting, put the epiglottis. When I show that video to the sleep therapist, the internal medicine doctor, the neurologist, the cardiologist, any doctor or technician, okay, that is it CPAP goes? Okay. The BPAP too? Yes, the BPAP too. The servo ventilator too? Yes, the servo. We need to take action there. Another clinical example, this patient is snoring, and normally, without CPAP. This is no CPAP, this is normal inspiration. Hear the sound. This is the little sound the wife tells us. It's like a shocking. This is without CPAP. Okay? The literature, the papers says the CPAP, the positional therapy correct the epiglottis collapse. Well, this patient in the right position, no correct. Okay, go to the left. Correct a little, because the patient don't want it's very difficult to put the positional therapy. We put the mat simulator, and you see 70% of protrusion, 5 millimeters of aperture, and look, almost yes, he correct, but in little point, and we need to think. This is the dentist option. This is your call. More forward or minor, because we have a little risks there, and in positional with the mat simulator, we don't have any correction there. We put the CPAP there, and is that the reason the patient don't want the CPAP, don't feel good in any pressure? Look, this is very important to see the variation of the pressure in the CPAP. It's not only for surgery. My sleep endoscopy is not only for surgery. I always tell the patients, I want to make a sleep endoscopy to put options in the table. More options, you feel good. Okay, how many options, doctor? 3 options. Surgery or appliances with different therapies, positional, myofunctional, whatever you want, and you choose. Okay, doctor, I feel good that. I feel good with it. This is the next step, the SAM. The simulator with more precision in the indication of the mandibular advancement device. This is from Dr. Patricia Fernandez San Juan from Spain, from Madrid. She's a sleep dentist, very clever, very nice, and very, very smart. And she invent this device. The selector advanced mandibulares in Spanish. Selector is you choose the advance you want in their maxilla. This is a little device. You put that copes, and you put it with silicone. The implant, the impression of your bite, and this is the form you can put it during this endoscopy. You explore the upper airway in the same time, and this is in neutral position. This is neutral position. Okay, we can move during the exploration, and the dentist open up. It's a minor, okay, and move forward, and we can see the variations during the sleep. We don't make a bad decision. This is with no sand, and it's with the sand, with the math, oral appliance. This is good because it's a more precision, more precision to a SMART. So SMART is very subjective. I think it's not a good. It's not a good. It's only for the saturations, situation during the sleep endoscopy. But our goal is solve the problem. This is the most important point. With any tool you have, with any surgery equipment, device you have, the oxygen level is very important in this kind of patient. With the patient, you present this video, and this is with the oral appliance. Without oral appliance, this is with your oral appliance. Okay, doctor, if it don't work, if you don't want it, okay, the surgery is that. You see the option, because in this field, the sleep surgery is very different to another fields. The last word, the patient have the last word, not ours. This is a quality of life surgeries. It's not like a appendix surgery. It's not like a trauma surgery. It's a quality of life surgery. You need to give the call to the patient. Because if you convince us to try to, yes, you want to use it, you want the surgery, come on, you can have, you are a good candidate. If the patient has little pain, the patient has a problem with the surgery, you convince me, doctor, and I feel bad. This is start the bad histories about that. In the last clinical example, DISE, this is our DISE now right now with the SAM, with the oral devices simulator, and with the CPAP. This is a young person with have a problem, a simple problem in the nose, with snoring. This is a very fit guy. Stop bank. The airport is 5. The apnea index is 27. The 120 apnea, hypopnea 72. The nadir is 84, and the snore is 174. But when I go to the sleep study, the patient is very surprised with this result. But look in the night. That is the sleep pattern of this patient. This is suffocating all the time. And you look the thyroid playing in his neck. It's very, very interesting this case. Go to the DISE. Previous the nose surgery I performed in this patient. We see this movement. Saturation. It's funny, but the nurses always look at us with the saturation. Doctor. Yes. Something else. All the nights doing that. Oh, sorry. Sorry, I picked the bad with the dog. And this is Is it item? Is it a video? But this is a short video. Sorry, the first part of the video is long. In this system, I can control the video. Is that the problem? Okay, pass to another. Please. Okay. Well, I show this video to the patient, and you know, it's the most incredible to see the reaction of the patients. Okay? This is the first part of the DISE. It's totally blocked in the pharynx, the tonsils, the palate, the pharynx, and open. Look the tonsils, look the palate, look the uvula. And look the neck of this patient. You see only this video, you think it's an obese patient and a big patient with a big neck. But you see it's not that kind of patient. And this is it's very important to see that in your sedation. Your anesthesiologist must to be a good anesthesiologist, because it's level of sedation with the bees, control bees, all that stuff. It's very difficult to get a good anesthesiologist. And this is a selector of the oral appliances, the simulator. You can see the numbers there, and I see the grades, millimeters we need, and use the 70% of protrusion with 3 millimeters of the aperture, vertical aperture. You see 3 millimeters there, 70%. It's a lot of millimeters. I don't think we can go forward. And you look the collapse there. It's still the collapse. It's still the snoring, but the oxygen is going high. And you know, this is very important to see with the sleep dentist, because the patient is still collapsed, the patient is still snoring, but the oxygen is going high. It's hey, what happened with the patient? It's going bad. Why? Still snoring. Okay, but is it snoring or apnea? This is very different point to view. Look, the epiglottis area too, all this stuff. The only variable we see with the oral appliance is the oxygen. Very important to see, because the symptoms are secondary to hypoxia, not for snoring. And this is my logo, and this is my logo, the logo of my dentist. Is that it's very important to work together, to get the psychiatrist, to get the cardiologist, to get the nutritionist, to get all that person you need in your group, in your team. We put the CPAP in the last part of the DISE, and you can see how the pressure of the CPAP can stabilize the upper airway. Yes, we need that. We know that. With this patient, the patient is going good, but in some pressures, the epiglottis stay in his side without problem. This is a different kind of patient, but I present you our protocol, how we can made our DISEs. This is one of the students I work with the Stanford and Portugal and Korean group. Yes, we did change my point of view when perform DISE, the effectiveness during the surgery. In this paper, Gianluca Janella from Italy, he showed good success rate. And in this honor article about the sleep endoscopy in pediatric patients, 133 patients, see an effective tool to make. And this study in that kind of study don't have any relationship with the success. But the problem is the surgery they choose. The DISE no push the new surgery. Conclusion: DISE is a safe tool, allows for trajectory management of snoring, important surgical planning, useful to detect causes of CPAP intolerance as another indication, and for research we need to evaluate the association between the preoperative findings and surgical outcomes. We want to see a lot of friends from this area, India, Nepal, Malaysia, all that people try to close to America. The door of America is Panama. I hope you can want to go. You can go maybe to go to Panama. The next year in April, we organize the next meeting from CIVICS. CIVICS is like a sister or brother association of IASSA, and we perform an Ibero-American sleep surgery meeting there. Panama is a very beautiful country in the middle of the continent. You know, a lot of flights connect Panama, and I hope to see you there next year. A lot of Indian friends, a lot of friends from this area can come. If you want to participate as a professor, please send a mail, send a letter, and we can arrange more attachment between our countries, between our societies. That is very important because we share the same patient, the sleep medicine and the sleep surgery. Is that the most important. This is for the young people here, the youngsters, the young surgeons. You want to get training. I'm very happy to see in India has a lot of opportunity to train. Congratulations for that effort, because that is very difficult to perform. In Mexico, we have only one center for sleep surgery. We have a lot of centers for sleep medicine, but it's not directly for ENTs. It's for a lot of specialties. It's somnology. But in sleep medicine surgery for ENTs, we don't have training centers. We have only one in Monterrey, my city. Is that the reason I think we have a lot of success in Latin America? Because a lot of ENTs from Latin America, we speak the same language, go to Mexico and go training there. But this is an effort to combine the power of the America, Mexico, a lot of patients like this. We can make surgery, hands-on surgery with the resident because it's a public hospital. The only responsible for this patient I am. This is the reason we can perform that. In New York, you can go with offer to see the American way to see the sleep surgery, the big wave of the sleep hypoglossal implants, the very different to see the medicine and the surgery in the United States, and go to Rome, to Italy, to see the ways to do in Italy. And Italy, you know, is one of the most powerful groups in the world in the sleep surgery. This is the contact. If you want to be part of this effort, you're welcome. And you know, some of my former fellows, we have 23 generations till today, and always I enjoy you, Indian friends. Always I learn with you. We will learn with you in the future courses. It's an honor to be here. I'm very happy to be here, and I want to say thank you.